So we will go ahead and get started. Good morning, everybody. I know the roads are really bad, so hopefully you're all safe and tucked in, I guess. Welcome to Medical Grand Rounds. Before we start, just a reminder that starting next week, we will be in Classroom D until June, which is wonderful for those that have been around for a while. Pre-pandemic, we were in Classroom D, so it'll be nice and familiar. And next week, I'll be giving my vision presentation. So hopefully you'll all be able to be there in person. I would like to respectfully acknowledge before we start that we are located on Treaty 6 territory, a traditional gathering place for diverse Indigenous peoples, including the Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, Dene, Ojibwe, Saulteaux, Anishinaabe, Inuit, and many others whose histories, languages, and cultures continue to enrich our vibrant community. I'm delighted to introduce our speaker today, Dr. Soumya Jayakumar. She's an associate professor in the Department of Medicine and is currently our adult gastroenterology program director. She is a hepatologist with clinical and research interests that include liver transplant, pregnancy and liver disease, and I can never keep up with the newest names. It's now MASLD and has published in the area of MASLD treatment and non-invasive risk stratification. Dr. Jayakumar has served as Director of Hepatology Fellowship Programs at the University of Calgary Cummings School of Medicine, and then held a leadership position in gastroenterology section at medical schools in both Calgary and at UBC, and we're fortunate to have attracted her here. She has a keen interest in trainee education and has served on national committees devoted to trainee education. She is on the She is the GI consultant to the Calgary Zoo, which I'm sure is a very cool position. She's going to speak to us today about DEI in medicine, the bastion of equity, or self-congratulatory backpatting, gender disparity in medicine and GI. Over to you, Soumya.
Thank you to everyone. Can you hear me? Okay. Thanks so much for having me. I will say I chose this topic back at the end of December. Was that or animal endoscopy? And I thought, okay, well, I think that the DEI thing will be much more applicable to a lot of people. But I chose this topic before a lot of the political changes in both Alberta and throughout the world. So this ended up being a lot more controversial, potentially, than I wanted it to be. So maybe I should have stuck with animal endoscopy. So going forward, I don't have any financial disclosures. Sorry. Okay. This presentation may contain some quotes, however, that may be offensive to some members of the audience. So I will warn you ahead of time. So for today, I thought that we start off by discussing the effects of gender in non-medical professions. We'll briefly review the differential treatment experience by BIPOC, LGBTQI, and female professionals in the work environment and in leadership positions. I do want to get you guys to understand the pitfalls of DEI in a medical setting amongst medical practitioners as it relates to their careers. And then we'll discuss the differential treatment female and BIPOC medical researchers experience in research and career promotion. So I'd like to start off a little bit just by discussing equity versus equality. So equity is treating all groups of people exactly the same and providing the exact same resources to everyone, regardless of their starting point. Equality is providing different resources to people through their various groups based on their different needs and access to resources. So if you think about it, equality is almost like having everyone kind of artificially starting them at the same starting point, but the end point may be very different, whereas equity really means that everyone gets to the same end point and you're providing the resources for everyone to get to the same end point. So I think a lot of people, and I know we're not supposed to call it DEI anymore, but for the purposes of this talk, I will continue to use the term DEI. When DEI initially first started coming out, I think a lot of people were like, is this just the 21st century version of affirmative action? So basically, interestingly, affirmative action in terms of the business sector. So this is, there was a study looking at hiring practices in US businesses with over 100 employees, starting from 1985 to 2014. So after the advent of quote unquote affirmative action. If you look at the effect of what affirmative action did, from 1985 to 2014, The number of Black men in those companies went from 3% to 3.3%. So clearly, affirmative action had a huge impact. The number of white women in managerial positions increased from 20% to 29%. So there was some improvement if you were a white woman, but you're going from 20% to 29%. So clearly not a significant improvement with the advent of affirmative action. Now, a lot of businesses do actually have mandatory diversity training. And ostensibly, that's supposed to reduce bias on the job and for performance ratings. So every time it comes up for promotion. And the point is also to try and decrease bias in recruitment and promotions. This is a study from Harvard Business Review, kind of looking at the percent change in 5 years amongst representation in managers. And again, this is around the area before they instituted mandatory diversity training and before they started introducing grievance systems for if you had a complaint with regards to harassment based on gender or racial profiling. And what you can see is that the advent of actually introducing diversity training and having grievance systems has actually worsened the number of visible minorities or women in managerial positions. So in terms of Black men, it can decrease it anywhere from 7.3 to 10.2%. Women decreased by 9% after you started implementing diversity training. And you're seeing the same thing with Hispanic men and women and Asian men and women. And part of that is because a lot of people feel that if you have forced diversity training, there is an instinct for people to rebel against it because they want to kind of be on their own and they're rebelling against the system and proving their own autonomy. And the positive effects for diversity training are really only felt for about a few days, and then things kind of fall back onto normal. So what this paper actually, Harvard Business Review actually suggested was that rather than mandatory diversity training, there's a ton of data to suggest that what actually improves kind of a more diverse group of people in a business is targeted college recruitment, mentoring programs, self-managed teams, and having social accountability. And those things have all resulted in improved diversity in the business world, as opposed to just saying, make sure you're doing your diversity training, make sure you're doing your understanding of implicit and explicit bias before you have your CARMS interviews. So there does need to be something a lot more than just mandatory diversity training. And you've noticed here I've put down grievance systems. There was studies looking at back in 2015, there was about 90,000 complaints made to the Equal Opportunity Commission in the US. 45% of those complaints actually included a charge of retaliation, which seems to suggest that when you actually present a grievance to your business place, what happens is that your complaint against your manager or superior is either overlooked, met with ridicule, or you actually ended up experiencing demotion or job loss because of that complaint. So having a complaint system doesn't actually mean that it's helpful. And in fact, if anything, it can be harmful. So this I thought was very interesting. This is a study looking at differential treatment in the legal field. And this is a survey by the American Bar Association. So when they did the survey, they found that female lawyers were much more likely to be mistaken for legal assistants, legal secretaries, and have decreased access to prime job assignments. And I see the women physicians in the audience smiling because I think pretty much every single one of us has at one point or another been mistaken for nurse, RT, custodian, janitorial services, food services. So, you know, it's good to know that it's not just in medicine. 57% of female BIPOC lawyers were mistaken for custodial staff or administrative staff or court personnel, like the stenographer, compared to 50% of white female lawyers, compared to 7% of white male lawyers. Female lawyers are more likely to be interrupted. And so there was a study looking at speeches made to the Supreme Court. And the reason that they chose the Supreme Court for this study is because there's a set group of justices, and lawyers actually present their case to the Supreme Court. And there's not really any extenuating factors, right? You don't have this amazing defendant or expert witness that's going to sway everything. Everything depends on you and your argument. Each side is given a set amount of time to present their case, but the justices can interrupt you in order to ask for clarification of a point. They can actually challenge your argument, or they can use that time to influence their other justices. So in this study, they actually found that female lawyers were interrupted earlier and more often. They were allowed less time to speak between interruptions, and they were subject to longer and more frequent speeches by the justices than their male counterparts. And again, it's easy. This is a great design study because there's very concrete criteria, and there's really nothing else that actually influences these other than gender. Interestingly, the justices also interrupted each other. 66% of all interruptions at the Supreme Court level were directed at the female justices. So this is back in the era of RBG, and we've got Sonia Sotomayor and Elena Kagan. So these are women that I think if you talk about who do you think of as a judge, right? Every single, especially as a female lawyer, every single person in the US is going to be able to name these women. So these are women that are recognized as being at the top of their field. And if RBG is getting interrupted, what choice does some lawyer from Podunk, New Jersey have? What choice do we as physicians have? Right? So I think it really goes to show that there is quite a significant difference between how men and women are treated, especially in the legal area. This is a study looking at how do we react when we make mistakes. So gender and the role of punishment for ethical violations. So ethicality is actually a term that is associated with traditional female stereotypes. So warmth, supportiveness, being good-natured and happy, smiling. And so violation of ethicality is actually taken to be much more offensive or severe when it's coming from women as opposed to men, because it's considered to be a deviation from standard gender stereotypes. So Kennedy et al. Actually did a very elegantly designed series of studies. So the first study, they actually had about 200 MBA students. And what they did was they were asked to read a scenario, and they were asked to rate the participant in the scenario in terms of, and it was usually a lawyer, they were asked to rate how well they thought that the lawyer was exhibiting features of moral traits. And these were actually based on a scale of 1 to 9, which was Goodwin's scale of high morality. And they found that the only defining feature that impacted the stereotypes for the hypothetical lawyer's warmth or ethicality or competence was gender. And interestingly, if the participant doing the study was a woman, they held men and women to higher standards. Whereas if the participant doing the study was a man, the ethicality and the morality was held to a higher standard for women, but not for men. So that was the hypothetical situation of looking at morality. The second part of the study was that they assigned about 200 students to, and they looked at MBA students because it's a business, and they gave them the situation of a hospital manager, this is in the US, who'd filed an erroneous Medicare claim, requesting a larger payment than should have been done. So the two things that they changed was gender, male versus female, and intent. So whether it was an accident, so looking at, I just didn't understand, versus whether it was intentional, in which case it was an ethical violation. And then they asked the participants to select an appropriate jail sentence. And in this hypothetical situation, women who made mistakes, regardless of what the intent was, were punished more harshly compared to men. And if you made a mistake that actually violated ethics, so if it was an intentional mistake compared to a man who'd made that intentional mistake, the women in this hypothetical situation received higher or longer times in jail. So, okay, this is all hypothetical. So the third part of the study, again, very elegantly defined, they actually created a database of Westlaw's all states database for 2008. And they looked at the ABA's censure of lawyers for ethical violations. And the reason they chose that was they didn't want to look at, say, something like in business, where it's something like you lost out on a promotion, you lost out on a bonus, because those are all very clearly, vaguely defined. And it's really hard to say, I lost out on a promotion, because that implies that you would have gotten that promotion. So what they did was they looked at ABA ethical violations. because the ethical violation was, it's clearly defined what the ethics violation would have been. And they looked at whether the lawyers receiving that ethical violation were publicly remanded or reprimanded or censured, whether they were placed on probation, whether they were suspended for a brief period of time, whether they were suspended for an indefinite period of time, or whether they were disbarred. And what they found was in 2008, out of 482 cases, they controlled for the number of judges on the panel. They also looked at the percentage of female judges on the panel. And they found that for the exact same ethical violation, female lawyers were much more likely to be disbarred compared to male lawyers. And it was actually 106% more likely for the exact same ethical violation. The interesting part was this was affected by the number of women on the panel of the disciplinary committee. So if the number of women on the panel was less than one standard deviation than the mean, and that could just represent one woman on the disciplinary panel compared to none, then everyone was more likely to be disbarred or have a much more severe sentence. But women specifically were significantly higher risk for being disbarred compared to if you had a minimum, or greater than one standard deviation of women on the panel. So it could have been, again, just one woman on the panel. And that actually resulted in improvement in, or more equalization of those, the censures. So what does that mean for medicine? So in 2020, the Canadian Women in Medicine Conference sent out a survey, and they conducted a survey asking women at the conference if they'd experienced any gender equity and what effect it had. So about 77% of respondents stated that they had experienced gender inequity either in training or in practice. And of those 77, 99% said that it actually had an adverse effect on their overall mental health. 83% of women said that the workplace had really nothing in support to support women in practice. And that's not necessarily talking about harassment, but simply things like the fact that women on average spend 2 hours, 100.2 minutes per day more than their male counterparts on housework and household activities. More men had leadership opportunities, but simultaneously, the men in leadership opportunities faced fewer and less severe consequences in the workplace for uncivil or disruptive behavior. And often, the women who did speak up were often called or labeled as troublemakers, and tended to then potentially, they felt that it had affected their ability to be promoted. So practitioners may often experience racism and sexism from colleagues, administrators, allied health, as well as from patients, and often with minimal support from their institution and being able to deal with racism and discrimination. Studies have shown that there's often a perceived difference between the treatment of female and male physicians, and specifically residents. And residents tend to experience a much higher gender bias in staff physicians. And there was a study by Doughton et al. And Doughton was actually, or is actually an RN who does a number of research studies in medicine. And she did a semi-structured in-depth interviews with nurses and actually gave them a number of theoretical situations, asked them to judge how they were going to interact, and what they would do. And things that she changed were literally just male versus female resident. And what she found was that nurses in the situation tended to have an us versus them mentality, but also ended up using fairly aggressive tactics in dealing with female physicians. They also reported that they were more willing to defer to male trainees and male physicians than female physicians. There were higher rates of mistreatment and discrimination by patients, families, and visitors to the hospital to both female and BIPOC physicians. And again, you can go complain if you feel like your supervisor is mistreating you, but who do you complain to when your patient is actually making racist or misgendered accusations to you? There's a meta-analysis of about 19 studies that found that BIPOC physicians experienced both overt and subtle discrimination, both in day-to-day incidents as well as regarding career advancement. And that seemed to be worse if you were born outside of the country, and especially if you had an accent, or if you were an IMG. And in the US, there's Press Gaining Scores, which is essentially like a hospital mandated rate MD. So basically the hospital asks patients to rate their physicians. And their rating is directly tied to your income. So the better your Press Ganey scores, the less likely you are to have your paid doc. You never make more money, you just make less money. So, as I said, I have an interest in medical training and have spoken a little bit about experience in medical training, and I do want to focus a little bit on that. So this is a study done by Ortho, looking at student perception of gender as a barrier to applying to orthopedic residency. And I'll say over the last 15 years, there have been more women applying to ortho. So in 2007, there was about 12% of female med students applying to ortho. That increased to about 23%. And part of that is actually because of programs such as the Perry Initiative and the Ruth Jackson Ortho Society. The Perry Initiative is actually where they have the med students are exposed to hands-on learning and hands-on experience in the field of ortho. So it actually exposes them to being with ortho and seeing staff working, but also recognize what life as an orthopod is like. And if you had actually gone through the Perry Initiative, your likelihood of matching to ortho went from 10% up to 20%. The Ruth Jackson scholarship is actually a mentoring type committee, but also associated with scholarships, research grants, and awards for women in ortho. Despite all of this, they've done statistical projection models, and they suggest, and the production models have come up with the idea that it will take 326 years before they can achieve gender parity in ortho, which I think if you think about it, in your mind, if I say orthopod, everyone's got the exact same vision in their mind. And so if any of you watch Dr. Flockin, this is ortho bro. And I think most of us think when we think of ortho, the stereotype is the frat guy who's working out, spends all of his time in the gym. And really, whether that's true or not, although really it's going to take 326 years to achieve gender parity, probably is true. I think this is the understanding that I think a lot of med students have. So if they do, why would they ever apply? So this is a 2025 study that they asked a number of residents at a single medical or med students at a single medical school about perceptions to applying to ortho. And whether or not they would apply. And so it's interesting. So they break it down to men and women. And so there are certain things like lack of personal interest or concern for competition, which are very personal. But I thought it was interesting that there was a difference in men versus women in their ability to find a mentor, as well as ability to shadow. And these were both statistically significant. So it sounds like with ortho, you're much more likely to be able to have someone who's going to mentor you and shadow. So both of which have been shown to increase interest in ortho, as well as the ability to get into ortho. And there's a gendered difference. Interestingly, when they actually asked these students whether or not they felt that ortho was a male-dominated field, 99% of female med students said yes, 77% of male students said yes. So I think we can agree that both the genders think that it's definitely very much a gendered specialty, just the degree of that, the degree of agreement to change. This is a very interesting study. It's a retrospective data of nursing evaluations from residents of nursing evaluations of residents in an emergency medicine training center. So essentially like 360 feedback. And what they did was they took in all of the nursing evaluations. They had one person remove all identifying names and pronouns. And then they actually sent it to the research committee. And the research committee was asked to classify the grading in terms of 4 main categories. One, whether there was anything stand out in the comments, and that could be either positive or negative. That meant that this person was noted to be very different from the rest of their cohort. Grindstone, which related to whether their work ethic. So in terms of ability, so whether that's medical knowledge or procedural knowledge. And finally, in terms of interpersonal. And these categories were actually based on prior academic work. And then what they did was they actually compared this to the evaluations done by, so objective evaluation, so results on the American Board of Emergency Medicine tests exams, as well as MD evaluations, so IDERS, feedback, things like that. So male versus female results in terms of MD evaluations, as well as ABIM scores or EM scores were completely the same between the two genders. However, when you looked at nursing feedback, women were much more likely to have negative feedback when it came down to ability. So whether that's knowledge or skills. So 51% of female trainees had negative results, comments from nurses compared to 20% of male trainees, as well as work ethic. So more women were considered to have less work ethic compared to the male counterparts. So 56 versus 24%. And then this is a study looking at discrimination faced by East Asian American medical students, about 300 participants. And the first one looked at, what kind of comments do you receive first off, if you're an Asian American? And so this was mostly kind of Chinese, Vietnamese, Filipino, Thai. So again, East Asian / Southeast Asia. So interestingly, if you're female and Asian American, you are much more likely to get comments about your gender and ethnicity than if you were actually male and Asian American. And same thing about gender and gender identity. But if you were actually gender diverse, you had much more comments about gender orientation, as well as disability. These are and so who's making access to information. Medical students, but it could also refer from other medical students, from family, and it could refer from staff, whether that means lecture or. So, up the US. What did that also say? Oh, sorry. Dropped everything. So this is a study by Shannon Rizicki in Calgary, who I've worked with, looking at workplace discrimination and harassment amongst Alberta residents. So this was a cross-sectional survey that they sent out to all of the resident physicians in Alberta through PGME, so both at U of A and at U of C. So of 1,700, a little bit over 1,700 residents, they had 195 surveys that were returned, so which is about an 11% response rate. And what they found was that they asked a number of questions, and they broke it down into white cisgender male versus female, and then BIPOC cisgender male versus female. And the reason that they don't have transgender, partly because then the data just becomes too granular and it's really hard to analyze. So do others assume that you work in a lower status job? If you were a white cisgender female, or if you were a BIPOC cisgender female or gender diverse, you were much more likely to have people assume that you worked in another job. Does your attending physician or your colleagues, do they ever direct racial or ethnic slurs, or do you feel like you're not taken seriously at work? So as you would expect, if you were BIPOC, you actually did experience people making jokes at you. And in terms of feeling ignored or not taken seriously at work, I actually thought this was interesting that the most common or the highest group of people that felt that they weren't being taken seriously at work were actually white cisgender men. But I think that that goes to show that a lot of our residents just don't feel like they're being valued or appreciated. This was also a different study by Shannon done looking at harassment reporting amongst Alberta physicians. So if you look at who has actually reported or experienced workplace harassment or discrimination, it's most commonly BIPOC cisgender women, followed by men, and then white cisgender women, with white cisgender men having the lowest rates of experiencing harassment. But in terms of, if you know where to report, the men know where to report it. If you're a woman or if you're BIPOC, you don't know where you're supposed to go and tell people. And not very many people do report, but if you do report it, really, if you're woman or if you're BIPOC, you're much less likely to be satisfied with the outcomes than if you were a male cisgender or white cisgender male. And this is in response to Shannon's study. This is the survey that she sent out. And I don't really want to read any of this. I'll give you guys some time to actually go through some of the responses to her survey, which is very disturbing. All right. Move on. So that's the trainees. What about if you're a practicing physician? So this is actually an Ontario study looking at surgical referral patterns and gender. This is looking at referrals made to surgeons in Ontario between January 1997 and December 2016, and they followed up to December 2018. So there was 40 million referrals made by about 45,000 primary care physicians to 5,000 specialists. What they found was that male physicians were more likely to refer to male surgeons, but female physicians were also more likely to refer to male surgeons. So if you look at kind of same gender referral rate, there was a 1.6% same gender referral rate if you were female, compared to 30.2% rate in men. The referral pattern from PCPs strongly suggested that the referral based on gender was influenced by adverse outcomes. So if you were a female surgeon who had an adverse outcome, so death rate, so annual rate of death within 7 days of a procedure, equivalent for men and women, 0.85 versus 0.72%, not statistically significant. But if you were a female surgeon that had an adverse event, that primary care physician was much more likely to never refer to you again. If you were a male surgeon that had an adverse event, you had zero effect on your referrals when you had an adverse event. So again, going back to what I talked to you about the ethicality and how women were punished more strongly for the exact same violation or exact same problem or outcome that men did. And the reaction is strongest amongst PCPs that just recently started referring to you. So they haven't built up that relationship with you yet. And then when you looked at gender versus specialist billing, men had more referral and they actually were referred more procedural and higher remuneration procedures than female physicians. And again, this is out of Ontario. I'd like to talk a little bit about maternity and paternity leave and the effect on professional advancement. So in the US, there's no fixed policy. And one study of surgeons in the US actually showed that about 50% of patients had paid 50% of surgeons had paid parental leave. 40% had no leave policy. And if you were taking leave, most of them were taking it out of their vacation or paid time off. And how much leave did you get in the majority of these? 1 to 2 weeks. And so a lot of times, if you took it, if you were in an academic center, you had more time off, protected time off, compared to surgeons that were practicing in a fee-for-service center or private center. But the problem was surgeons in a private center returned to work because of financial issues. Surgeons working in an academic center returned to work because they were worried about academic advancement and how that was actually going to affect their ability to move forward. And it's not just women. There's actually this study looking at, they surveyed program directors to ask them, do you give your male residents pat leave? The majority of them, of the hundreds of general surgery programs in the US, only 40 general surgery program directors responded. 50% told them that they gave their male residents 1 week of pat leave. The majority of them did not give any pat leave. And anyone who requested pat leave actually had much more harassment than women requesting maternity leave. Because again, it's that whole perception of deviation from stereotypes. So if you were a guy requesting pat leave, you actually had much more harassment coming your way than if you were a woman requesting maternity leave. So this is, again, showing that this is really a problem for everyone. And what does that mean in terms of academic promotion? This is actually a study in New England Journal showing that women were much less likely to be promoted and took a longer time to be promoted. So in general, looking at rates, so there's about, if all of the academic centers in the US, only about 30% of them have women that are full professors, despite the fact that 50% of their group were actually female assistant professors. So there was a decreased rate of promotion from assistant to associate, and then from associate to full decreased even further. So women tend to have decreased rates of promotion. And partly that's because of what promotion entails and what you need in order to be promoted. This is again looking at Shannon's study, looking at leadership positions. So in terms of who holds a leadership position, mostly white cisgender men. And if women are compensated for leadership, they're actually compensated for leadership in small committees as opposed to actually taking leadership roles. Most women did not have time allocated for leadership, and if they did, it was because they were on an EDI committee. EDI in the US, or what it used to be in the US. So in terms of gender and academic promotions, as I said, only about 26% of full professors and 30% of associate professors in all of the US medical schools were women. And promotions determined by productivity and external recognition. Female physicians, if they were recognized for institutional service, which is really hard to get a promotion out of. And keeping in mind that productivity, more female physicians spent their time applying for grants, thereby decreasing productivity, but they're much less likely to get grants. So at the end, you spend all your time applying for a grant, you don't get the grant, and now you've spent all this time not being productive, so difficult to get promotion, and you have nothing to show for it at the end. So in terms of actual promotion based on productivity and external recognition, it becomes really hard for women to get promoted based on these things in terms of merit. As well, in terms of external recognition, women are much less likely to be asked to speak at conferences. So only about 30% of, if you look at a lot of large programs, especially if you look at kind of like, unfortunately, BBDW and KEG, a lot of times only 30% of women are, or 30% of speakers are women. So you're less likely to be asked to speak. And so if you're not getting productivity and you're not getting external recognition, again, the decisions to ask people to speak really come from a committee. There's not necessarily something that's an objective metric. So how are you getting promoted then? And often application for promotion is a very arduous, time-consuming, and above all, mysterious process. Not dissimilar to choosing the Pope. I don't know if you guys saw this, but yes. So how does that translate over into leadership and research in GI? So I'd like to talk a little bit about gender representation in gastro. So in the history of KEG, only 2 out of 47 presidents have been women. OAG, so Ontario Association of Gastroenterology, none of the presidents have been women. Quebec's doing pretty great with 2 out of 15 of their GI presidents being women. And the Alberta Society of Gastro has 1 out of 5. So Alberta's doing the best. In terms of university GI division heads, in 2018, it was 0. 2020, it was 1, which is, up to 13%. However, if you look at university GI program directors, that's where women tend to be leading. But even that, women only occupy about 1/3 of leadership for GI program directors. And at the CAG annual conference, it's only about 1/3 of speakers. And if you look at, females in leadership positions by year, really pretty low if you're looking at those numbers in terms of division heads. And if you look at overall gastroenterology, of all of the specialties looking at the heads, GI does pretty poorly compared to internal medicine, transplant hepatology, or actually total surgical. So all of the surgeries together have more division heads than GI does. There's also a gender gap in leadership for GI. So as I said, of the 10 academic or university GI departments, only 1 has a female division head, Dr. Shargonic. And there's actually a leaky pipeline. We lose women in GI. So about 54% of the med school class is women, but 48% of those who graduate are women. So we lose things going from Med 1 to Med 4 already. 44% of the internal medicine residents are women compared to 1/3 of GI fellowship candidates. And then when you go from GI fellowship to practice, we go from 33% to 15%, and they don't actually comment on where we're losing all of those women. I don't know whether some of them choose not to practice, but this is, again, this is looking at the US as a whole. So we may be losing people to going into industry or just into research. Now, if you look at areas of leadership, 1/3 of women in leadership tend to be in the role of fellowship directors. Only about 1/10 are GI division head, and anywhere from 14 to 33% are department chairs. When they are placed in roles of leadership, women tend to have a higher incidence of their division colleagues weaponizing their hospital complaint process against them, as well as a more difficult time And I think the two most common examples that I can think of in Canada are going to be Dr. Irene Cybulski and Dr. Teresa Kaiser, both in cardiovascular surgery, who were heads of their divisions and had so many complaints made by their male colleagues, so many investigations called for into their outcomes, despite the fact that their outcomes were no different than their male colleagues, to the point that they both ended up stepping down. And in Dr. Cybulski's case, she went to law school, became a lawyer, and then sued them. So what does that mean in terms of grants? And I'll speed this up. So there's a lot of studies looking at the role of gender in terms of grant applications, and including in the Lancet. So this, the study in the Lancet actually analyzed application success amongst about 24,000 grant applications from 7,000 unique PIs. This is actually a change from CIHR. So prior to 2014, the traditional grant program focused just on your application for the study. After 2014, you could either have the stream that they looked at the grant program that focused on the study, or they started focusing more on the scientist and like the PI's CV and the PI's ability to obtain, either present, get published, or get other grants. So prior to the institution of this PI specific grant application process, it was relatively equal. So there wasn't really a huge difference between men and women being awarded grants. Afterwards, there was a significant difference and much fewer women were awarded grants. And again, this goes back to what are your opportunities? What's your ability to get external recognition? And if that's what part of your ability to get the grant is based on, regardless of what a great idea you have, what the possibility of actually making a study that goes to completion, as well as a study that's going to change practice, that doesn't really matter as much as what's your CV. And so it becomes a vicious cycle. So what's your CV? You haven't gotten any grants, we're not going to give you any grants. Okay, we're still not going to give you any grants because you still don't have any grants. So this change in 2014 actually made things quite a bit worse. And this is actually a retrospective study of about 55,000 grants and about over 4,000 patients, and looking at the grant application process. And they found that women actually got about 1/3 of the grant awards and 40% of the personnel award applications, and they had a significantly lower success rate. So what do we do now? So again, going back to that table of equity versus equality, equity means that equality means you treat everyone the same. Equity means that you recognizes that there's differences in the resources that people have, and trying to make up for that when you give people resources to help improve them and get them to succeed. Justice is actually changing the entire system. So we can focus as much as we want in equity versus equality, but doing so will actually make things worse, because this is where you have that perception of, oh, you're just, you're just a DEI hire, or, oh, you got this job because you're a woman or you're BIPOC or whatever. Whereas if you start changing the system itself, so you focus on merit, but you also take into account the differences in abilities that people have. And so, for example, like grants, you focus on the topic and not who is applying. That's changing the system, and that's justice. So although DEI committees are a good start, I hope I've shown you today with this evidence, we still need to do something, but DEI committees on their own are not really the single solution to institutional racism and misogyny that's present in a society, and specifically in the medical field. And that's kind of goes to my talk. So I think a lot of times, a lot of companies, a lot of hospitals are very happy saying, we have a DEI committee, we have mandatory DEI training, and then they say, and that's it, we're done. And I think what we really need to do is change things at the level of making things different, doing at societal level, or at least society within the medical field level. So do we do central triage? So that decreases the referral bias against female physicians. Higher proportion of female, BIPOC, LGBT physicians on committees. So not just DEI committees, not just education committees, but overall committees. And we can only achieve that if we start encouraging these groups to apply for promotions and leadership positions. as well as supporting those people that are in leadership positions who are from an underrepresented group. So if you have someone who's had multiple complaints and it keeps on happening by their colleagues just because they're in a leadership position and they don't like them, rather than kind of investigating every single complaint, at one point, recognizing the fact that these are fictitious complaints and saying, we're not going to do this anymore, and actually supporting the woman or BIPOC person in power, as opposed to taking every single complaint as though they have equal merit. The promotions process should be reviewed and overhauled. So basically, there's a number of different things that we can do. So one of the things that you could do is, do we do it as an automatic process with a yearly review with your division head and your department head? When I was in UCSD, everyone got promoted. The thing was, you had 10 different levels of being an assistant prof, another 10 different levels of being an associate prof, a number of different levels of being professor. But every year you met, there was a checklist of things. Did you meet this? Did you meet that? Okay, you went from assistant 1 to assistant 2. You went from assistant 2 to assistant 3. So everyone automatically got promoted. There was a chance that you at one point, may take a while, you went from assistant to associate as long as you kept meeting very well set out metrics. And you went from associate to full prof, again, as long as you met very well set out metrics. It wasn't based on a meeting with a number of people from different committees, including people that are not in medicine, to make that decision. It was based on very well set out defined criteria. And the best part was, all you brought with you was your CV. And you're like, this is what I've done in the year. And your division head would just be like, all right, sure, good. You met this, you need to do this, you need to be on another committee, and you're getting a promotion. It wasn't, okay, let me take off 2 weeks so I can put together my promotion packet. The other things that we can do is actually having a committee or mentor to meet with each specific person immediately prior to their yearly review to discuss promotion. Maybe having senior faculty give junior faculty templates of what you need to do to apply for promotion. The other thing that's actually been suggested is each person should actually have both a male and female mentor. And part of that is because as a female physician, having a female mentor, most female physicians, most women, generally tend not to have a self-promotional aspect of things. We don't have that mindset. And having a male mentor, maybe someone who's actually going to encourage you to think about things in terms of, this would actually be really good for promotion, something that you may not have thought of and something that another female physician may not have thought of. On the converse side, having a female mentor really helps because you have someone who's been through things, who's been through the same things that you have. And so having the combination of the two is really helpful. And this is maybe actually helpful, not just for female physicians, but also for male physicians as well. Grant committees, maybe we need to go back to 2014. And Netherlands actually did a study where I didn't go into it in the interest of time, where they've reevaluated their overall grant committee process. And now they have a 50-50% rate of successfulness in terms of male and female scientists. We need to go back to the science-based evaluations rather than evaluation of the PI. Do we do it as gender blind? So we don't have a name, and that also effectively removes the ability for any potential risk of racial bias as well. Or do we create more funding for female researchers, recognizing the fact that this will create some anger and unhappiness for the people that will automatically see this as, or perceive this as being something that favors women over men, and that men are feeling like they are being targeted. I think that we need to have zero tolerance for the old guard that commit infractions of harassment, bullying, racism, sexism, and that if we actually have someone who has an ethical violation or who has a complaint process, men and women need to be treated equally and punished equally. And when you have this occurring from patients or from patient families, we need to have a hospital support pathway in place for dealing with abusive patients and debriefing encounters set up, as well as how to handle this. If you talk to the college is essentially saying, unless you feel like you're in danger, that patient is yours forever, regardless of what they say or how they abuse you, unless they, are threatening you. But that also impacts quite a bit on your own mental health. So maybe we need to have something else in place, especially if you're in a group of people and you say, listen, this person is really horrible. Do you mind taking this person for me? Like, can you take over care? And I think especially in a quaternary care center where you have a huge group of colleagues that do have similar areas of subspecialty, that works out well. Works out less well if you're out in the rural area and you're the only doctor. But I think if we have the ability to do that, that's something we should do. So this is what I probably should have talked about. But I'll open it up to questions.
Thank you, Soumya. It was such an eye-opening presentation, and we hear about it, but when you have the data to back it up, it really sort of opens your eyes. And the whole idea of justice over, I know Lindsay's provided that cartoon in one of our newsletters, but it's really nice to see it over and over again. So I know we are limited for time. Just one thing I was going to say is, a lot of what you talked about in terms of justice, I have had the opportunity to see many, in terms of promotion, many universities sort of moving to the model that you talked about. Unfortunately, we are bound by collective agreements and so on, which hampers, how much we can do. But I think to get that message out is really, really important. Any questions in the room before I go online?
And sorry, I just want to say with regards to promotion, especially in GI, one of my colleagues in McGill, named by Lancet as one of the top 40 most influential physicians in the world, is the only female full professor in the history of GI in McGill. So if that's what it takes to be a full professor, I can't imagine that they have any other full professors there. But obviously that's not the case.
Well, and that leaky pipeline that you talk about, right? Okay, so I do want to end on a positive, and that's by bringing up this question. It's that one might surmise that there may be generational effects here. To what extent have studies controlled for this, and are there data to suggest altered attitudes in younger individuals, or does that normal distribution persist? And this question really caught my attention because I have the pleasure and opportunity to learn, to spend a lot of time with learners. And I am seeing a bit of a shift, in terms of more interest in surgical, GI, cardiology type specialties than, maybe my generation. Certainly more mentors, that are available in those areas. And also just a shift in terms of medical students, sort of standing up for themselves, if nothing else. And so I wondered if you had any data to that effect.
Yeah, so I think obviously I don't have data in terms of the leadership because that group or that generation has not yet come into the period of their lives where they're going to be occupying leadership positions. But yes, there are studies looking at just kind of general overall allyship, right? In terms of calling out when they see something going wrong, as well as being very conscious of having safe spaces and using words that are going to be less insulting or hurtful. And within kind of, say, resident groups, there does seem to be more of a trend towards moving towards more equity. Having said that, with Gen Z, so a group of like 18-year-olds right now, there is, I said I wouldn't get political, but looking at what happened in the US, when you interview white males in that kind of 18 to 20-year group, there is a reason that they predominantly ended up voting Republican. Part of it is because you have this entire group of people that their whole lives they've been told that they're the villain, they're the reason that other people aren't succeeding. And they're getting sick and tired of being told that they're the fault. And so, unfortunately, what happens is that you end up getting this swing back of the pendulum back to kind of, I need to look out for myself. So I think we've got a very small window where we had the potential for equality between groups and more of men speaking up for both their female counterparts as well as their BIPOC and transgender counterparts. But now I think I worry that we're going to start seeing a swing back.
Yeah, I mean, if any of you that saw the news yesterday, it's heartbreaking. I mean, I was almost in tears hearing about the rhetoric that was going on about diversity hires and things like that. So we do have time for one more question, so I'm just going to jump in here with this one. Any studies assessing the sexism and racism experienced by female and racialized faculty from trainees and learners? There's a perception that this is a huge problem that we don't hear about, but is a lived experience of many faculty, and racialized faculty are most often silenced to, sort of bring this up.
So and I'm not saying that there's no data, but I did not find any data myself, but I agree anecdotally, if you do talk to racialized faculty, especially BIPOC female faculty, yes, there is actually anecdotally discussions that racialized female faculty are treated differently by their learners. And it's interesting because it's not just male learners that are treating them differently, but it's woman-on-woman violence. So you see female trainees also treating their female staff differently than the male staff. So I haven't seen any studies, but that would actually be a really good thing to look at, because it's definitely something that I think I hear a lot of from my colleagues.
What a fantastic presentation. And I know there's people waiting out there. So I do have to end it here, but thank you so much. And really looking forward to hearing more about this and doing more about it.